Professor Mano Sharma for his excellent arrangement of this e-learning series. And now we will invite our moderator, Professor Madhab and Professor Kanda. So our moderator, please.
Hi. Is there Mahatab? Professor Mahatab? No? My name is Tatsuo Kanda from Japan. Today's first speaker is Professor Dijal Toripasi. Is there? No?
Sorry, he's not arrived yet, sir.
Okay. First speaker, Dr. Senzoro Marco. He's a famous doctor. Now, current position is consultant in gastroenterology and hepatology, gastroenterology, University Hospital of Padua, via Giustiniani, Padua, Italy. Today's his talk is my algorithmic approach to management of acute variceal hemorrhage, esophageal and gastric in cirrhosis. Professor Senzoro, please.
So, thank you very much for the invitation and the presentation. I'm going to start with my presentation. Sorry. Good. So I hope you see my screen. So we will speak about management of the acute variceal bleeding, both esophageal and gastric. Acute variceal bleeding is a fourth event of acute decompensation in patients with liver cirrhosis, according to both canonic and predict studies. Mortality consequent to acute variceal bleeding has dropped down along the decades thanks to the diffuse introduction of the vasoactive treatment soon at admission and the important antibiotic prophylaxis in these patients. And in the recent decades, mortality now is about 15 to 10%. The most recent series from the USA confirmed that the mortality following an acute variceal bleeding episode in a very, very large cohort of patients is around 10%. But if we want to further improve survival and to maintain this high survival in these patients, we have to manage the patients really well. And the management is more important when the non-endoscopic things to do are considered. And in fact, the medical and the pathological management of this patient is even more important during acute esophageal variceal bleeding than the endoscopic parts, in my opinion. Therefore, we must take into consideration that the antibiotic prophylaxis is a mainstay since it decreases survival and decreases the risk of rebleeding. But despite the antibiotic prophylaxis, we must take into consideration that about 20% of patients can have antibiotic resistant to, for example, third series cephalosporins, especially when inside the sea, when we manipulate the airways, even with the position of the nasogastric tube. And mostly of these infections are in the respiratory tract, following by urinary infection, therefore need to be managed by different antibiotics, like it was like an hospital-acquired infection. we must restrict our transfusion strategy, and this has been demonstrated by two cohort randomized controlled trial, which showed an improvement in survival in patients with child A and B cirrhosis with the restricted transfusion strategy compared to liberal transfusion strategy. And this has been shown since the 1999 when at Royal Free Hospital was shown that the complete restitution of the blood volume lost resulted in an increase in portal vein pressure. This is why probably we do not want to transfuse too much these patients to avoid the increased risk of failure at endoscopic hemostasis. Consequent to that, we should avoid to correct the coagulopathy of the patient. Therefore, the lab abnormalities we see in these patients, the prolonged INR, or even the platelets count. Because with aggressive resuscitation with crystalloids, blood products, FFP, we just increase the CVP and the pulsar pressure, we cause hypocalcemia, hypothermia, and we dilute probably platelets and fibrinogen, further increase the bleeding on the varices. So what is recommended is just to correct the dilution coagulopathy if we need to transfuse a lot of blood products in these patients, and that's also do not correct lab abnormalities. Endoscopy in this patient has to be performed soon, but not very soon. The medical management is so important that probably if we perform the endoscopy like an urgent endoscopy within the 6 hours, like in this randomized controlled trial, the study, we increase the mortality in this patient. Therefore, what is recommended is to perform endoscopy within 24 hours and within 12 hours in patients who are a little bit unstable, and therefore it seems to have an active bleeding that needs to be treated before the 24 hours. So airway manipulation, as I showed to you, needs to be avoided. Prophylactic intubation to perform endoscopy needs to be avoided in all patients because this increases both pneumonia and mortality. Therefore, what is usually recommended is to protect the airway if there is a severe uncontrolled variceal bleeding with hematemesis, if the consciousness is compromised with grade 3 and 4 by hepatic encephalopathy, it has aspiration pneumonia already, or difficult maintaining oxygenation in these patients. If we fail endoscopy, if we need to go to tamponade, we can choose both the stenting or the balloon. These are two different devices. The stenting has less aspiration, no need of intubation, can stay there for several days, so allow planning of secondary procedure, the definitive procedure. But it aimed only to esophageal varices within, within the last 15 centimeters of the esophagus, and therefore balloon can be used for example, mid-esophageal bleeding or gastric type 1 varices. Needs to be remembered that in my experience, the migration of the stent is even more than 1/4 of the patient, as you can see in this picture. And therefore, in my opinion, is a little bit more than what is reported in the for example, randomized controlled trials or some studies. And therefore, it can then cause a rebleeding in these patients. But if you ended like this, and you need to try to avoid to end like this, you need to go for emergency tips in this patient in which the hemostasis is high, but the mortality is still very high. It's about 1/3, 1/4 of the patient. And you need to try not to allocate to this treatment patient who are futile to be treated, and therefore usually with a high need of inotropic support, very, very advanced child P class, maybe greater than 14 and 15, who will die anyway. And the failure of endoscopy is not, I'm not able to achieve the primary hemostasis, and therefore I need to go to a salvage procedure, but also an early rebleeding, which is correlated with a high portal pressure and can happen in about 50% of patients in this subset of patients. Therefore, and usually it happens within the first 3 days since the first bleeding. That's why it has been created the concept of the preemptive tips in this patient, which is the allocation to tips treatment after the first hemostasis or the bleeding within the 32 hours of admission. And this has been shown to be effective in randomized controlled trial in which the allocation was according to portal pressure greater than 20 millimeters of mercury or according to the severity of liver disease. This treatment that has been shown to be greatly effective in reduced mortality in all these trials in patients with child B greater than Q7 and in child C patients, and even in patients with very advanced liver disease with acute on chronic liver failure, we see that preemptive tips still have an advantage. So the presence of a CLF shouldn't be a contraindication to allocate the patient to preemptive tips. So the guidelines of Baveno at the moment recommend this as a grade A of evidence in the patient I've mentioned before, with an allocation according to clinical characteristics, so severity of liver disease, active bleeding, and child Puke B7, or if we want to, we have a possibility to measure portal pressure in those with the portal pressure greater than 20. Therefore, this is the algorithm I should choose. If it is after the first bleeding, after the control, if it is too much severe to be allocated to a preemptive tips, EBL plus drugs. If it is within this category that I've taken together, the category I've just explained to you, a preemptive tips as soon as possible. If it is a low risk, we can go with a prophylaxis with EBL and drugs, and then allocate if it is a failure already or it will develop a failure. However, the allocation to the preemptive tips is difficult, and in real life, you see the percentage of patients who are really allocated to a preemptive tips after variceal bleeding, and this is because there is no network. There is sometimes no tips availability in that center. It's difficult to move the patient to another center because it's critical. There is some disbelief in the physicians in the benefit of the allocation to this treatment, but these scarce resources, no clinical networks, scarce ICU beds, for example, in my center, despite we are a third of a center, it ends in an increased mortality if we do not allocate these patients. And so we will see patients that would have needed to be allocated to the preemptive tips, but they have not. Therefore, the secondary prophylaxis is very important, and we must remember that the medical treatment, the response to non-selective beta blockers is cardinal. It's cardinal because there is no difference between beta blockers when we add EVL in the survival in these patients, and beta blockers plus EVL are superior to EVL alone, especially where the patient has decompensation. So the control of portal pressure is the mainstay in the long-term follow-up. Nevertheless, we can have a lot of bleeding if they are not responders to non-selective beta blockers during the follow-up. Therefore, we must consider to place the tips in this patient even when they are not responders or there are contraindication to the use of non-selective beta blockers in the secondary prophylaxis, because they will bleed with a very high percentage, as you just saw. Therefore, this is another indication to tips placement during the follow-up. And we must take into consideration that in some patients in which you have some doubt whether it is indicated to allocate the tips in secondary prophylaxis, you can use still the HVPG measurement to guide treatment in specialized centers and in some patients with a use a la carte. Gastric variceal bleeding is different. Is more severe, usually is linked to a higher mortality, is about 30%, has a higher percentage of rebleeding, requires more transfusion than endoscopic, that is esophageal variceal bleeding. Therefore, what is important in the management of a gastric variceal bleeding is less probably the control of the portal pressure, and you will see why, but more the anatomical staging. And I think that in this type of bleeding is more important endoscopic technique and what we do to those varices compared to the esophageal one. In fact, we all know that the indication to treatment, endoscopic treatment, is with obturation, with the use of glue, of cyanoacrylate. But despite this has been recognized as the first line treatment endoscopically, the percentage of rebleeding in this patient is quite high, and it remains high. And this is because the anatomy of these varices are very variable. And it's important to classify the anatomy and to therefore to perform a CT scan, a second line imaging to anatomical staging these varices, which have different inflow pattern and different outflow patterns with the gastrocaval shunt or gastrorenal shunts. And this anatomy is correlated to what we see at endoscopy that is classified according to Siren classification. And therefore, usually what I recommend to use is a Caldwell classification, which classify the varices according to the present to the lesser gastric curve or gastric fonda, and according to the inflow of these varices and the outflow, mainly if there is or there is not a gastrorenal shunt. And this ends in a classification according to the presence or the absence, for example, of the contemporary esophageal varices, the presence of the gastrorenal shunt, the patency or not of the splenic vein, which correlates with what we have to do and how we can treat this varices, and I will show to you later. Therefore, the anatomical staging is very important, and the indication to a first line approach with the endoscopic treatment, in my opinion, can be reserved to those with active bleeding or very high risk signs of earlier bleeding before anatomical staging, and therefore because allocate the patient to other treatment. And if as we speak to the technique that is recommended, is a little bit different. You do not have to wash the fibrin clot. You prepare bending or looping for GOV1 that can be used, can be treated as the esophageal varices, and the glue injection needs to be done for IgG1 and GOV2 varices with the straight cyanoacrylate to decrease embolization. Do not touch the fibrin clot, inject few millimeters away from the clot, and be sure to be really intravaricial. Just stick the needle inside the varices to avoid the submucosal injections and further formation of the ulcers and the bleeding for this reason. And try to use the right amount of volume So injectors no more than 1 ml and no rapid injection to avoid what are possible collateral effects and in particular extra GI embolization in these patients. It is being reported that when you try to treat them endoscopically, the adjunctive use of EUS can increase the rate of obturation of these varices, and a recent meta-analysis have shown that there is some advantage without any difference in early bleeding, but low rate of later bleeding in these patients. So, for example, this is a clinical case that I think that is interesting. You perform an endoscopy, there is severe gastric vessel bleeding. You see this sign, a nipple spot with hematine. So you have to decide whether to treat or not. But in this case, I had the anatomical staging as well. He had a portal vein thrombosis, a diffuse HCC in this patient. You cannot see from this phase, but a very huge real gastric varices in this patient with a big gastrorenal shunt. Given the local availability sometimes of the expertises, the radiological intervention possibility in that day, in that time, you can decide to treat the patient. And therefore, I try to treat the patient. So this is the first attempt of injection in this patient with gastric varices. You have seen that the CT scan were very major. The true gastric varices were about 4 centimeters, the whole bunch of them. So this is the first treatment. I injected 2 ml because the volume, the varices were very big. So I tried 2 ml, 1 ml of saline solution after the 2 ml to wash the needle. So first bleeding after the injection, not happy. I've tried the second time, another 2 ml of injection, and it started a very, very, very severe variceal bleeding from the site of injection, and with a very, very high pressure, as you can see, without possibility to stop it endoscopically. So I tried the rescue therapy with hemostatic powder, which was the effective a temporary hemostasis, but the patient then, despite the interventions, died. So maybe this complex patient with this complex anatomy needs to be allocated straightforward to another radiological treatment, not to be touched endoscopically. In this context, the TIPS has a higher percentage of bleeding because, as you can imagine, with this big shunts, portal pressure is low, so they can bleed even at lower portal pressure, lower than 12 millimeter of mercury of gradient, and therefore the obturation of the shunt is the mainstay in the treatment and is much superior to TIPS in the control and the secondary prophylaxis of the patient. The method of obturation can vary in the patient. We can treat the gastrorenal shunt retrogradely with the BRTO, for which we have less experience in Europe, but we can then approach the patient also anterogradially, closing the inflow of the gastrorenal shunt amongst TIPS or, for example, percutaneously. So the classification of Sand-Caldwell indicates what is better as a treatment for the patients. So the occlusion of the shunt per se, the placement of the TIPS plus the occlusion of the shunt, or for example, if the splenic vein is completely closed, you do not have access there, the indication to use splenic embolization to treat cardiofundal varices, for example. The evolution of the technique to occlude the shunts has been evolved. So now we have vascular plug assisted BRTO, so not with the indwelling balloon, the coil assisted retrograde occlusion of the shunt, and also the PATO, which increase the efficacy of the occlusion and decrease the possibility of spillage of the material used to embolize the shunt into the portal vein. But, for example, this is what I use in my center. In some center, you have to consider when you have cardiofundal varices, for example, the more important collaterals dominant afferents are the posterior and the shorts. And if you do not have, for example, important esophageal varices, you are very close to the spleen there. So, for example, this is a case in which there were those afferents and a big gastrorenal shunt without esophageal varices and the recent bleeding of cardiofundal varices IgV1. Therefore, it's classified as type 2 with gastrorenal shunt, as I explained to you, with these two afferent veins. So what I have tried in a series of patients, and this is my experience, that you can use VRTO, but you can also use an anterograde approach, transsplenic. That's we do in our center. We puncture the spleen, we enter the splenic vein, and we embolize the two afferent, so closing the inflow to the gastrorenal shunt. This has resulted in a good result at CT scan with a very, very good result, for example, at endoscopy. And my experience, the series of patients have done it like that. There are no increase in portal pressure if you select the patients without esophageal varices, with severe decompensation and without rebleeding during the follow-up, but needs to be published and expanded as a series. And if we want to keep it simple, very simple, we can think that we have a bleeding from gastric varices, especially IgV1 and GOV2, and you have a splenorenal shunt. If this splenorenal shunt is decreasing a lot of portal pressure, you can occlude them. You can occlude it directly or retrogradally without thinking that it will decompensate the patient a lot. It will further aggravate esophageal varices. If you have portal pressure increased, you think that the patient is at risk of decompensation after the closure of the shunt for the worsening of portal pressure. So you can go for TIPS plus coil embolization of the afferent if the flow is still there. And if you do not have splenorenal shunt, if you go straight for the TIPS, this is a simplified algorithm that can be also proposed. So, three short take-home messages, because it's very complex, the algorithm. So, I believe that in esophageal varices, the medical treatment and the complex management of the patient is the mainstay, and treatment, the allocation to secondary prophylaxis is very important, and therefore we must choose the right patient at the right time to allocation to TIPS placement. In the gastric varices, the anatomical staging is essential. You should perform a CT scan as soon as possible when the patient is ill to guide the treatment, and as I showed you, also to guide radiological treatment as a first-line approach in some patient, and therefore is very important. An integrated pathological management with very skilled interventional radiologists to improve survival in these patients. Thank you very much.
Thank you, Professor Senzoro. After the second speaker talking, we will discuss the about your presentation. But is there any comment from Professor Dogmeji?
Thank you very much, Professor Sanzala. It's an excellent talk, really. And of course, gastric varices bleeding in portal hypertension is very challenging. And sometimes we cannot really stop the bleeding, even though we perform injection therapy or even tips. My question is, what is your mortality rate of gastric varices bleeding in portal hypertension in your cases?
I must say is less than 10%. We go straight to a secondary prophylaxis with radiological treatment in this patient, try to close the shunts and so on. Therefore, I've showed you a very recent and very severe case, but usually the mortality is not that high because we use all the options of the treatment, the radiological treatment we have got very soon. And I think that this is important because every episode of mortality, every episode of bleeding leads to a very high risk in these patients. It needs to be allocated to radiological treatment very early.
Thank you.
Thank you. Professor Abbas? Okay. The Professor Mahatab?
Yes. May I ask the question now? Because there was some
Oh,
problem.
okay, Abbas.
Yeah, thank you very much. Professor Sanzalo, it's a very informative presentation. I just want to know, sometime we come across varices that we call ectopic varices, like from the duodenum or from the rectum. So what is your approach in dealing these varices? Suppose if we see some varix in duodenum, should we inject the glue in the duodenum or should we go for Berto or some other process?
But endoscopic treatment of ectopic varices is very challenging. You can stop the bleeding acutely, but the rate of rebleeding is very, very high. So we go straight to tips with embolization of the varix. The embolization of the varix is very, very important along with tips, because if you perform tips alone, it has been shown that you have a 40% of rebleeding rate. So the embolization of the shunt is important. For example, also for rectal, you can embolize when the flow is retrograde. For example, in the inferior mesenteric vein, you can embolize whatever you want. You're not cause ischemia. Therefore, you have not to worry about that.
Yes, thank you. After second speaker, we will discuss more together with Professor Senzaro. Is there Professor Mahatab? You may please introduce Prof. Dahad. Second speaker. Mahatab? No?
Not there. Professor Kanda, you please introduce the next speaker also. Thank you.
Next speaker, Professor Tijera Tripasi, consultant hepatologist and clinical director of research at University Hospital Birmingham and honorary professor at the University of Birmingham. Professor, please, let's start your talk, please.
Thank you very much. Can you hear me okay?
Yes,
Great.
please.
Thank you. So thank you very much for that introduction. Apologies for slight lateness. I got the time difference slightly wrong. So I'm going to just share my slides. So I'll be giving this talk live. So okay. So again, thank you, APASL and panel for inviting me to give this talk. I will talk about my algorithmic approach to primary prophylaxis of variceal hemorrhage, esophageal and gastric in liver cirrhosis. Or an alternative title could be Paradigm Shift, Should Beta Blockers Be Given to Everyone? Because of the emerging evidence. These are my disclosures. So I'm going to start my talk with just a bit of background on the pathophysiology of portal hypertension and varices. I appreciate some of this may have been covered by previous speaker. So in cirrhosis, one of the first events that occurs is the development of increased intrahepatic resistance, which really results in the slowing down of the portal venous flow and a reversal of flow in more advanced cirrhosis. And you have an imbalance of vasoactive mediators, which results in quite marked spastic vasodilatation. So there's increased flow and also increased resistance driving portal hypertension. And as you'll be aware, there is the development of photosystemic collaterals in the lower esophagus and the stomach and other parts of photosystemic anastomosis and the development of varices. In terms of targets for therapy, obviously we have the non-selective beta blockers, propranolol, nadolol, and carvedilol, which I will talk about later in my talk. And also there is variceal band ligation as an option for therapy. And we already heard about the management of acute variceal hemorrhage, and TIPS is obviously an option there. So the hepatic venous pressure gradient is really key, and I will talk a little bit about the importance of the hepatic venous pressure gradient in the assessment of portal hypertension. So this is really measuring the portal pressure, where it's a surrogate, a good surrogate of the true portal pressure in sinusoidal portal hypertension, such as alcoholic-related liver disease or viral hepatitis. Not so good if it's pre-sinusoidal, for example, early primary biliary cholangitis. And what you will see is a tracing of the wedge where there's occlusion of the hepatic vein, and then the free pressure, and the difference between the free and the hepatic, the wedge on the free hepatic venous pressure is the hepatic venous pressure gradient, and this has been used extensively in studies and in research and in clinical practice as well. This is an important paper. It does date back quite a long time, nearly 20 years now. So this is the kind of original timolol paper assessing timolol versus placebo in patients. Now, this is really important. These are patients who do not have varices, and the HVPG threshold here was 6 millimeters of mercury. So at a very early stage, and the primary outcome was a development of varices or variceal bleeding. And in fact, the primary outcome was actually no difference between timolol and the placebo arm. However, very important findings came to light during this with this study. The very important finding was that the baseline HVPG was really very predictive of the primary outcomes. So if a patient had a baseline HVPG of greater than or equal to 10 millimeters of mercury, they had a much higher risk of developing the primary endpoint, which is the development of varices or bleeding. And also the response to HVPG was also important in terms of the primary endpoint. And this really led to the definition of clinically significant portal hypertension as being greater than or equal to 10 millimeters of mercury. And this is just a diagram just illustrating, we often call this the Baveno stages of cirrhosis. So as I've said, the portal hypertension becomes clinically significant at this 10 millimeters of mercury threshold. And we have really 6 stages here. On the left, we have compensated disease, and you have 3 stages all the way up to the development of varices. And decompensated state is where there is bleeding or first or other decompensation, and patients can, in some cases, develop acute and chronic liver failure and sadly pass away. But patients in the decompensated state can actually recompensate. For example, if there's treatment of the etiological driver like antiviral drugs, or if the patient abstains. So what's really important is to appreciate the difference between the compensated and the decompensated state, and in terms of patient outcomes, which are profoundly different according to whether patients is compensated or decompensated. And this is just a nice study showing the hemodynamic changes that occur as the liver, as you go into from the clinically significant portal hypertension and then into the compensated and to the decompensated state. As you can see, there's quite a significant rise in cardiac index, a reduction in the systemic vascular resistance due to this marked slackening vasodilatation. And as you would expect, a rise in the HVPG, a reduction in the mean arterial pressure. So there is what we call this hyperdynamic circulation, which progresses with increasing severity of liver disease and the sympathetic drive. In terms of the history of varices, which is obviously what we're interested in this talk, is the primary prevention. So in the cirrhotic patient, there's roughly 5 to 12% annual risk of developing small varices, and then these small varices can progress to medium to large varices, which can obviously bleed. The medium to large varices have a much higher risk of bleeding than the small varices. And in the UK, we're conducting 2 large clinical trials looking at primary prevention in small varices, the BOP trial and also the Caliber trial. These are both active at the moment, and hopefully the results will be available in the next few years. And this is an important diagram taken from Bavino workshop. This is so-called the rule of 5. And what you have is these are liver stiffness measurement thresholds. So up to 10, then 10 to 15, 15 to 20, 20 to 25, and over 25. And patients who have a liver stiffness measurement of less than 10 kilopascals, they really have a pretty much classified as pretty normal. Consider monitoring if ongoing injury. And then these patients who have the higher liver stiffness measurements, they have a more higher risk of developing a clinically significant portal hypertension. But if they do meet this criteria, they can have a very low risk of clinically significant portal hypertension. So it's pretty predictive of ruling out clinically significant portal hypertension. And also in this region, going up to 20 millimeters, 20 kilopascals. So this is so-called the Bavino 6 criteria to avoid endoscopy. So if a patient has liver stiffness measurements really of less than 20 or platelet of over 150, they can be spared an endoscopy. Splenic stiffness measurement can add additional precision if available. Now, as we go into higher liver stiffness measurements, then we call this is often called the gray area. So here, maybe not quite so precise in defining the risk of clinically significant portal hypertension. And once you hit the 25 kilopascals, this is where you're really into the clinically significant portal hypertension territory with really specificity and positive predictive value of over 90%. And splenic stiffness measurements can increase precision in untreated viral hepatitis. Now, this is really important. This threshold, this is really only applicable in patients who have Hep C, Hep B, alcoholic liver disease, and non-obese NASH. Now, patients who have obese NASH, and by that I mean BMI really over 30, their prevalence of CSPH is so much lower at this liver stiffness measurement of 25 kilopascals. So they require a different approach, and this is the kind of anticipate NASH model, which takes into account other factors such as the body mass index and the platelet count. And a nomogram is, as you can see in the slide, can be used to determine the probability of clinically significant portal hypertension. So patients who have obese NASH, they are quite different. And as we all know, most of the patients who attend a fatty liver disease clinic actually have a BMI of over 30. And there are clearly some caveats with regards to vibration control transient elastography. There is a risk of false positive, particularly in the postprandial state. It is hepatic inflammation or even a lot of alcohol consumption. And really the liver stiffness measurement, if it is increased, it must really be repeated in fasting conditions if not done already, and can be complemented by fibrosis markers, which as you can see, can be dependent on the etiology. So the etiological driver is really important in interpreting the non-invasive markers. So what about primary prevention? That's a bit of pathophysiology. Now, this is a clinical scenario, which we probably see all the time. Patient with compensated active cirrhosis, grade 1 varices without red signs. Would you start carvedilol? So let's go through some of the data. So we have, in terms of primary prevention, we have two real options, as I've mentioned in the previous slide. There's band ligation. Clearly, it has been shown to be effective compared to no treatment, and technique is important. I don't routinely ban small viruses. There is an increased risk of adverse events, as you can see here, with bleeding, ulceration, or even stricture formation. So it is invasive, and certainly not without risk. Beta blockers, we're all familiar. These have been around for decades, and they work by reducing, so it's non-selective beta blockers work by reducing cardiac output with the beta-1 blockade, and also reduce lightning flow due to unopposed alpha-1 action due to beta-2 blockade. And this, overall, there's a reduction in portal pressure due to reduced flow. Now, it's important to note that there is a difference. Not all beta blockers, non-selective beta blockers, are the same. So propranolol, there's about a third that don't mount a hemodynamic response. And propranolol was the first, really the first non-selective beta blockers that was used in liver cirrhosis and portal hypertension. This is just to give you an idea of the dosing regimens and the key indications. So with carvedilol, I would normally work to a dose of 12.5 milligrams over 24 hours. Really going above that dose doesn't really increase the efficacy in terms of reducing portal pressure. However, if a patient's compensated disease and a systemic hypertension, then you could increase the dose to treat systemic hypertension. Propranolol often titrated to heart rate or the mean arterial pressure, and normally you don't need to go much above 80 milligrams BD. Now, this is an important study, really assessing the difference in response to beta blockers, whether you have, dependent on the presence or absence of this clinically significant portal hypertension. So this is a group of patients who had HVPG measurements. Most had HVPG over 10 or equal to 10, and some had HVPG which didn't quite meet the CSPH threshold. And they were all assessed with acute response to intravenous propranolol. These patients were actually used for the Prodisky trial. Now, unsurprisingly, those patients that met the CSPH threshold, there were more patients that had varices, collaterals, more splenomegaly, and higher liver stiffness measurements. And also, importantly, those patients that had clinically significant portal hypertension, they had a significantly more response to intravenous propranolol. And the CSPH was an independent predictor of non-selective beta blocker response. So really, patients need to have developed this kind of hyperdynamic circulation with the CSPH before there is an effect of non-selective beta blockers. Now, carvedilol, again, it's not a new drug, but it has been used extensively in portal hypertension, and some would say this is the drug of choice now. It's a third generation non-selective beta blocker. The main difference is this additional action of alpha-1 blockade, which reduces intrahepatic resistance. And as I've said, the dosing is important. I would normally start at 6.25 and then work up to 12.5. There is quite marked hypertensive effect, and in advanced liver diseases, we'll come on to, it has to be used with caution due to the effect on blood pressure. And this was one of our original studies showing this marked reduction in the HVPG according to the dose. We used the 12.5 milligrams. Prior to this, group led by Peter Hayes, we'd used higher doses in patients who were just dropping off because of hypertension, just collapsing and having syncope all the time. So we felt that we had to go to a lower dose. So this is one of the earlier kind of phase 2 studies. So looking at evidence, you'll be familiar with the levels of evidence. This is the Oxford kind of classification. Really at the top, you have got systematic reviews of RCTs, and then individual RCTs, and then lower levels of evidence down to 5, which is just expert opinion. So I like this diagram. So let's focus on the compensated patients. So these are patients that have not had bleeding ascites or any encephalopathy. This is an important study, the Prodisky trial, which is really looking at patients who had what we call super compensated liver disease, absolutely no previous decompensation, no hint of decompensation at all. These patients had HVPG, which met the CSPH threshold. Most had viral hepatitis, and most patients had small varices. And there were 8 hospitals in Spain that were involved, and 631 patients were screened in total. The primary outcome was decompensation or liver-related death. The patients were either randomized to propranolol if they were responded to acute propranolol, or carvedilol if they were not a non-responder to acute propranolol, and there was a placebo for each arm. The important thing is patients who varices developed progressed to larger varices, they were offered band ligation in both arms, and randomization was 1-to-1. The key results here, as you can see, the primary outcome endpoint was the liver-related death or decompensation. After about a couple of years, there was a significant difference in favor of the beta blocker group, with a hazard ratio of 0.51 and an NNT of 9. And the effect was greater if small patients had small varices, non-alcohol related liver disease, or if there was a HVPG response. And there was a greater HVPG response with carvedilol. Bleeding was pretty low. And importantly, the liver stiffness measurements at baseline actually had pretty low precision in predicting decompensation or death. So it wasn't that precise in this particular RCT. And unsurprisingly, patients who mounted a HVPG response with a drop of over 10% or to less than 10 millimeters of mercury had a significantly less incidence of the primary outcome. And the main difference was really this development of ascites. And death wasn't significant, but it was close. But when you had the composite endpoint, there was a significant difference in favor of the beta blocker arm. And what we've done is, this is a paper that's been recently published. Some of the authors may be actually in the audience here. So what we did was we looked at four trials, and including the Pradisky and the carvedilol trial that I was involved with, and also studies from India and Pakistan, really focusing on carvedilol and patients with cirrhosis. And an individual patient meta-analysis was done, led by Amy Bosch and Candid Villanueva. So the aim was to assess whether carvedilol can prevent decompensation and improve survival in patients with CSPH. So all these patients in these trials had CSPH because they all had HVPG criteria or had varices. So there were 4 RCTs, and as I said, it is individual patient data meta-analysis using a time to event competing risk regression model. And overall, there were 352, 181 in the carvedilol arm, 171 in the control arm, and 92 received banding, 92 received placebo. And most had varices, and the etiology mainly was viral hepatitis. So in terms of results, there was a significantly reduced risk of developing decompensation with carvedilol, with hazard ratio of 0.5. There wasn't any significant heterogeneity. And also, importantly, the survival benefit was even greater, with almost 60% improved survival. And the side effect profile, slightly more side effects with carvedilol, but there was no difference in severe side effects between carvedilol and the control. And if you look at the data in a bit more detail, what you see is that the benefit is really seen in patients who have esophageal varices. The numbers are small of patients that didn't have esophageal varices, but really it's the presence of esophageal varices that seems to indicate patients that are likely to benefit the most. So the conclusion was that long-term carvedilol reduced decompensation and improved survival in compensated patients with CSPH, and that screening patients, compensated cirrhotics for CSPH and starting therapy with carvedilol can improve outcomes. Now, we also looked, this is a work in progress, it's published as an abstract. This is now looking at patients who have high-risk varices. So we conducted an individual patient data meta-analysis of 11 RCTs. These patients had high-risk varices, and overall there were 1,400 patients. And if you look at just the compensated patients who had compensated liver disease, there was no difference in mortality overall, but if you looked at just the compensated patients, there was lower mortality with the beta blocker arm, and no difference in side effects. And also there was no overall difference if you looked at band ligation versus beta blockers, but there was less bleeding with the combination of banding or beta blockers, although there was heterogeneity there. And there was no difference between the different types of beta blockers. So in compensated liver disease, regardless of the size of varices, you see a benefit of beta blockers in terms of survival. So these are the Baveno consensus statements. So and some of them are quite new. So the beta blockers should be considered for prevention of decompensation, and carvedilol is preferred for some of the reasons I've already highlighted. And patients with compensated cirrhosis on beta blockers for prevention of decompensation don't need screening endoscopy, because endoscopy isn't going to influence the outcome. And in patients who have the larger varices, but who have contraindications or intolerance to beta blockers, band ligation is recommended at first line to prevent variceal bleeding. No indication to use non-selective beta blockers without CSPH. And patients who are compensated and not candidates for beta blockers for the prevention of decompensation should undergo the screening according to this kind of Baveno 6 criteria. So a second kind of a clinical scenario, a patient who has, and this is quite a hot area for debate, is a compensated patient who has a liver stiffness measurement of 30 kilopascals done in ideal conditions. Would you start carvedilol without an endoscopy? There is no explicit statement in the Baveno consensus statements to advise you to start beta blockers purely based on non-invasive testing. It can only be inferred that liver stiffness measurement of over 25 is a good surrogate of CSPH. But we don't have actually any control data to say that treating patients with this liver stiffness measurement threshold improves outcomes. And as I've already said in the Broditsky trial, it was liver stiffness at baseline was not that precise in predicting decompensation. And the evidence to start beta blockers based on non-invasive tests really needs to be generated. So far, there is some modeling and decision curve analysis with some papers from India, recent paper from India, but there isn't actually any evidence. So certainly it's likely that there is likely to be a benefit, but we don't actually know because we don't have the data. Now, if we look at decompensated cirrhosis, what about decompensated cirrhosis with high-risk varices that have not bled? What would you do? So we're now talking about the decompensated state. And again, going back to this individual patient meta-analysis, if you look at only decompensated cirrhosis, this is band ligation versus beta blockers or a combination of beta blockers and band ligation. There was really no difference in the overall mortality or bleeding. And the only difference that we saw was over time, there was possibly in decompensated cirrhosis, maybe a trend towards maybe increased mortality in non-selective beta blockers. But again, that's small numbers, no difference in side effects. So in decompensated cirrhotics, I think you can use either beta blockers or band ligation. A combination probably is not worth doing, and it increases adverse events. So in decompensated cirrhosis, Venus 7 workshop, so these are patients who have ascites and small varices, no red signs, not child PUC, can be considered for traditional non-selective beta blockers or carvedilol. Large varices, yes, you would definitely treat, and carvedilol can be, or any non-selective beta blocker can be used. And a word of caution, and in patients who have ascites, there is some evidence that beta blockers can be detrimental, but you need to be careful with patients who have low blood pressure or who have HRS AKI. You should withhold, but then reinstitute beta blockers once the patient has recovered. Now, gastric varices, we've already heard quite a lot from the previous speaker. As we know, they have a different anatomy. There can be the presence of splenorenal shunting, bleed less frequently, but with higher mortality and transfusion requirements, and often seen in non-cirrhotic portal hypertension. So what would you do? Medium-sized gastric varices, IgV1 that have not bled, what would you do? So there is a paper from India, Professor Sarin's group, which showed that beta blocker propranolol reduced bleeding in GOV1 and IgV1 less of over 10 millimeters size. There was better survival in cyanoacrylate versus placebo. And despite a drop in the HVPG, there wasn't really a significant benefit of using non-selective beta blockers. BR-tumor, we've already heard a lot of data from Korea, China, and Japan, mostly in viral hepatitis. I think there is potentially a role, but we don't really have that much evidence. And as we've heard, there is a risk of aggravating esophageal varices. And remember, it's just still a major intervention in a patient that's not bled. Very different to a patient that has bled already. So I think there is potentially more data needed, and also more data needed for some of the other endoscopic therapies we use in our center. We use thrombin combined with coil embolization via endoscopic ultrasound. And it has been very successful, but there isn't a lot of controlled data. So the Baveno consensus statements has suggested that non-selective beta blockers, even in this scenario, can be used to prevent decompensation, and highlights the study that I've discussed, and doesn't really recommend BRTO or BATO or TIPS in primary prophylaxis of gastric varices bleeding in compensated patients. And in terms of just round off, this is kind of my suggested algorithm. So I was involved with the British Society of Gastroenterology guidelines. These are now dating back to 2015. What we said at the time was patients, and this is in the era we didn't before really the Baveno 6 criteria for screening or current thinking on prevention of decompensation. We would have recommended grade 1 varices not to treat and re-endoscope, higher grade varices to start beta blockers, but things have changed. So we're in the process of putting together British Society of Gastroenterology guidelines, revising the guidelines extensively based on the recent data. So what would you do in compensated cirrhotics? Now, if you have access to HVPG, yes, then if HVPG meets the CSPF threshold, you could start beta blockers and then leave it at that. They don't need to do any more. But just about every center in the UK does not have access to routine HVPG measurements for all of these patients. So what we would do is we would normally do liver stiffness measurements, use the Baveno 6 criteria. Sometimes we also use splenic stiffness measurements to add precision and use that to select patients for endoscopy. Where there isn't access, and there's still a lot of centers in the UK that don't have access to fiber scanning, then we would, no varices, we would normally survey, and small varices, survey or enter into the BOP trial. In the small varices patients, I think carvedilol may be considered if there's active liver disease. So I think more and more people are thinking about carvedilol. Large varices, we certainly offer prophylaxis, and these are the patients that have been included in the Caliber trial, and probably carvedilol is likely to be the preferred beta blocker here, even over band ligation. In decompensated cirrhosis, again, we do have the clinical trials running, so we do include some of these patients in the clinical trials. And here, I think you can either use beta blockers or band ligation. And again, once you've been started on primary prophylaxis, you don't really need further surveillance endoscopy. And so this is quite a nice diagram. And some of you will be aware of the therapeutic window, which was introduced by Craig a number of years ago. This is an update. So it's the therapeutic window for beta blockers in cirrhosis according to stage of disease, the benefit of beta blockers, type of beta blockers, and the evidence. So in terms of the benefit, so in the red, there's no benefit. In yellow, possible, and green, there's definite benefit. So if the patient has to prevent bleeding, really, there's certainly benefit if you have small to large varices and higher stiffness and pressures. Reducing mortality, again, you're probably looking at more larger varices to reduce mortality, to prevent decompensation. I think even in patients with small varices, there is a role for beta blockers to prevent decompensation. And also there's a lot of debate about which beta blocker, and carvedilol up to a point probably, although I would argue you could probably still use when there's decompensation, but carefully taking into account the blood pressure and renal function of the patient. And in terms of levels of evidence, so really you've got quite a lot of evidence for patients who have the small to large varices, and for patients who have the small varices or no varices, there isn't so much evidence. So beta blockers for everyone. Yes, if there's clear, significant clinically significant portal hypertension and compensated cirrhosis, more data required for using non-invasive criteria to select beta blockers in compensated cirrhosis. and decompensated cirrhosis, the beta blockers effect are not so marked and could possibly be detrimental. And band ligation clearly has a role. And as I've said, the two large clinical trials, we've recruited in total nearly about 700 patients or so in these two trials. Hopefully they'll provide some additional insights. We're looking at also mechanistic aspects, health economic aspects, and also very importantly, health related quality of life, because beta blockers have lots of side effects. Some of them are, really can have an impact on quality of life, and patients may not always tell you. So we're looking at that aspect as well, because there's no point taking a drug if it makes you feel miserable. So this is something that we're looking at closely in our trials. Okay, and thank you very much. That's the end of my talk. I'm happy to take some questions.
Thank you, Professor Toripasi, about your primary prophylaxis of varicella hemorrhage based on your experience and recent Babeno 7 consensus workshop meeting. Now we will discuss the two speakers. And I have one question, Professor Toripasi. The timing of endoscopy, Babeno 7 criteria recommend the timing based on platelet count and liver stiffness. And now, almost all patients with viral hepatitis can be controlled. And patient with NASH, sometimes they have obesity, and we cannot always use the elastography for these patients. How about your opinion for these patients?
Thank you. Really, very good questions there. So as I mentioned, I think we really need to realize that the vibration controlled transient elastography has its real limitations, and it's still surprising that, you know, as you mentioned, NASH patients with almost everybody has a BMI of 30 or more. They're really a different group, and what we're seeing, it's not just liver stiffness measurements, but also other studies have shown that even patients who have HVPG of less than 10, they can actually still have varices. So even HVPG may not be that reliable. So I think this is an area that probably requires further thought and thinking. And I'm not so keen on relying purely on the liver stiffness measurement in the NASH patients. I would probably have a lower threshold to proceed straight to endoscopy in these patients, because clearly if you see varices, that is really important. And almost any size of varices, you can actually now consider to start treatment to prevent decompensation. Now, your other question about the viral hepatitis and SVR, that's really important as well. And although I haven't said it in my slide, and I think this is because the evidence base is not quite as strong, but patients who have SVR and who don't have who've got low liver stiffness measurements above less than 25, well below 25 kilopascals. Now, there is a group that you could potentially stop beta blockers, but Baveno is very careful and say you need to repeat an endoscopy. And that is, I think, level C evidence. So to stop endoscopic surveillance and beta blockers, you need to see clear evidence that there isn't any ongoing clinically significant portal hypertension. And that's, I think in viral hepatitis, you could be more confident with using vibration controlled transient elastography. So there is a role, but as I said, it's kind of level C evidence. So it's not so strong. And you wouldn't be wrong to continue, but you'd need to, if you're going to stop a beta blocker in these patients, you would need to repeat an endoscopy and be sure. Again, this is where you kind of use your own clinical judgment and acumen that there isn't any evidence of any ongoing active etiological driver before you stop beta blockers.
Thank you. And concerning using carvedilol, how about the patient with diabetes? Diabetes mellitus patient.
This is again a very good question. So in the clinical trial that I was involved with when I was in Edinburgh, published in 1999. So we had a number of patients that carvedilol can influence diabetic control. It can actually make diabetic control worse. I saw it in just a couple of patients. We had to stop the drug because it resulted in a deterioration of diabetic control, and potentially also insulin dependence may also hamper the hypoglycemic awareness. So I think you need to be careful. So clearly there is the alternative beta blocker, which you could use propranolol. But again, it's about a discussion with the patient and also with the diabetic team as well. So with the patients that I've discussed, we actually closely involved the diabetic team, that there could be an influence in diabetic control. But what was important is that there is a clear indication. So again, it's about patient selection and making it clear to the patient why you're giving this drug, and also to the diabetic team to be more, maybe more cautious and carefully monitor the patient.
And thank you very much. Professor Jagam Abbas, please.
Yes, thank you very much, Devraj, for this excellent presentation. Can you hear me?
I can, thank you.
Okay, thank you very much. Actually, I am become a little bit confused in the sense that are there any clear-cut cutoffs for stopping beta blockers when you see a patient with decompensated cirrhosis of liver? And what should be our choice? Because there are many studies now that show that actually this adversely affect the prognosis if you are continuing your beta blockers in patients with decompensated cirrhosis of liver. So how much careful should we be, and when should we stop giving beta blockers, and should we continue with another beta blocker instead of carvedilol like propranolol or nadolol, or we should completely stop all the beta blockers?
So yes, I mean, this is an area of significant interest. Now, yeah, so I think with carvedilol, there is the extra alpha-1 antagonism, extra effect on hemodynamics. So as we are aware, with more advanced cirrhosis, there's quite a lot of sympathetic overdrive, and carvedilol can have an influence on that. However, having said that, the data, and I have to acknowledge that the data is based on observational studies, not so much randomized trials. It doesn't always suggest that the carvedilol is detrimental. In fact, a study that I was involved with, and also my colleagues in Edinburgh, they've showed that patients on carvedilol with advanced cirrhosis can actually have better outcomes. So what I do is, I think I just use kind of clinical judgment. So if a patient comes in on carvedilol who's got a low blood pressure, say a systolic blood pressure of 85, you're going to have to stop the beta blocker. And if they have, and there could be a reason why the blood pressure is low. They could be septic, they could be SBP. You need to look carefully for the reason for the low blood pressure. You can't always blame the beta blocker. And then you would monitor the patient off the beta blocker. And I try actually to reintroduce carvedilol when the patient is better. And often you treat, they could just be hypovolemic and dehydrated, or they could have a bit of sepsis. They get better, and then I'll reintroduce, but at a small dose. Sometimes I've used just even 3.125, really small dose and work up, because the bioavailability of carvedilol is significantly higher if you look at the stereoisomers, much higher in more advanced liver cirrhosis than in early stage cirrhosis. So you really need to titrate the dose. And if they're not tolerating carvedilol, this is where I would think about propranolol. I don't always go straight to propranolol. I still prefer, if possible, to use carvedilol even at a lower dose. I appreciate practice may be different elsewhere, but I try to keep the patients maintained on a beta blocker. And there's even more reason now, because obviously with the COVID pandemic, our endoscopy services have been severely hampered. And I think during the pandemic, we had virtually no endoscopy. So that is all you have. You've just got the beta blocker. So we're very keen to maintain the patients on beta blockers. And I think you've seen the Marco's slides on secondary prevention as well. I think the need for beta blocker is key. It's when you remove the beta blocker, that's when outcomes are not so good. So I'm quite keen to keep going with the beta blocker and obviously carvedilol if possible, but I have no hesitation using propranolol if I'm not happy with carvedilol.
May I ask another question? So you asked about, you told us about fibroscan or KPA being used to start a beta blockers. So what should be the cutoff, like even in the absence of varices, if we see that this is so much KPA, like 25 or 30 or whatever, we should start giving beta blockers to prevent decompensation. So what should be the cutoff for that?
So I think that this is a difficult area, that there isn't enough data for me to say that I will start beta blocker. I mean, the CSPH cutoff, this is in viral hep, alcohol-related liver disease, and non-obese NASH is 25. Now, I wouldn't see that as if I saw a patient with compensated liver disease with a let's say liver stiffness measurement of 28 under ideal conditions, I wouldn't see that as necessarily to start a beta blocker. I would always use an endoscopy at this time, unless I have access to HVPG. So if you want to look at data and evidence, the Broditsky trial clearly showed HVPG greater than or equal to 10. If you start a beta blocker, then a patient can benefit. But access to HVPG is very, very limited in a lot of centers. So I would still think endoscopy has a role. And as I've shown in the individual patient meta-analysis, it's actually patients that had endoscopy, that had varices of any size, that actually had the benefit. Because when you see varices, you can be pretty confident that is clinically significant because varices progress and bleed.
Like some of the studies show that if you are KPA is 40 or so, then the chances of decompensation increase. So if we see patients having 40 KPA, should we start beta blockers to prevent ascites in these patients, or should we not?
There isn't evidence. I mean, I think there's probably nothing. You probably wouldn't be wrong to do it, but it wouldn't be based on hard evidence. I mean, I think, yeah, you can make a case to start, but you need to generate that evidence, whatever it is. It might be difficult to do a placebo-controlled trial in that scenario, but some sort of study or evidence, maybe a multi-center study to show benefit of beta blockers beyond just modeling. I know there are a number of models out there, but we want to actually see proper hard evidence and clinical endpoints.
This might be even more true in patients with NASH. Even if we have access to HVPG, we have like 1/3 of not concordance between HVPG and the real portal pressure because of the pre-sinusoidal fibrosis. Therefore, I think that those patients need to be screened with endoscopy to allocate to the beta blockers.
Any comment, Professor Dogmeji?
Yeah, thank you very much. It was a really wonderful talk. I have the question, similar question. There are potent beta blockers like propranolol and carvedilol. As the speakers pointed out that, carvedilol more effective than propranolol. My question is there any special group of patients we can select the use of propranolol?
So, I mean, obviously, that in terms of primary prophylaxis, if there is, what we do know is, and because I'm not aware of a kind of a head-to-head trial, carvedilol versus propranolol, what we do know is that carvedilol is more effective in reducing portal pressure than propranolol. I think that's been shown. And also, very importantly, there's a significantly increased number of responders to carvedilol than propranolol. So if you want to be confident that carvedilol is having the desired effect of reducing pressure, I would say carvedilol would be the first choice. And it is on the whole really well tolerated in the compensated disease. So I think in compensated patients, there's probably most would agree carvedilol is the drug of choice over propranolol. In the decompensated state, then it is more, as I've discussed, it is probably you can use both drugs. Some, and there's nothing wrong with doing this, some would start straight with propranolol. Some would go with carvedilol. I don't think there's a clear difference there. We didn't see that in the individual patient data meta-analysis with 1,400 participants. We didn't see a clear difference between the beta blockers. So I think in the decompensated state, your choice is between propranolol and carvedilol probably hasn't. You probably aren't going to see the same degree of benefit compared to the compensated cirrhotics.
Thank you.
Thank you, Professor Tripati. We will next discuss about the first speaker's talk, Professor Senzoro, about management of acute variceal hemorrhage. First, you talk about timing of endoscopy at the variceal bleeding. You recommend us within 24 hours. But more earlier, endoscopy is not good at your talk. How about your opinion about the timing of endoscopy?
I still believe that I mean an endoscopy, as you saw, since the failure of the primary hemostasis in very severe patients can happen, I mean within the third 3 days. I think that within 24 hours is a reasonable hour. However, the real evidences about the timing are not so consistent across studies, and probably the real patients who benefit with an early endoscopy, those who do not respond very well to resuscitation, is still hemodynamically unstable and still an active bleeding or bleeding. But what we should avoid is emergency bleeding, emergency endoscopy, like they are calling it 2 at night. The patient has bled 2 hours before, is not stabilized, not well managed, and this is what should avoid. Usually in the slides I show that letter, which I really like. It shows a good night, sleep tight endoscopy can wait until morning light, which is a thing that I like to show to my SPRs where they are calling during the night at 3 or 4 in the morning for an endoscopy for varices. But there are, in some studies, even that we publish as an abstract in EASL, actually there is not that strong correlation even between endoscopy done within the 24 hours and the outcome of patient, unless they are hemodynamically unstable.
Thank you. And concerning the treatment for gastric varices, in Japan, our country, national health insurance system did not approve the chips. So initially, we usually try to stop the bleeding by cyanoacrylate monomers injection, glue injection. And next, we will try to BRTO. And usually we did not use the chips. Maybe I think the etiology of varices may be different in your country. And how about CT scan timing after the treatment of them?
Anyway, recently I have seen a lot of cardiopulmonary varices correlated with gastrorenal shunt. So I think that the prevalence and the type of anatomy is not that different in your country compared to mine, actually. And I think that for this reason, the anatomical staging needs to be done as soon as possible, even with an urgent CT scan within a few hours of admittance, because you need to plan the treatment. It is different from the endoscopic one as definitive treatment in patients who have that chance of that kind of anatomy. Therefore, I think it needs to be done as soon as possible. And the tips can be still be allocated to the patient who has no chance. So, but they can be treated also endoscopically with a good success rate. And I think that those patients without chance and with lesser curve varices that can be treated also endoscopically without correction of the obturation by radiological intervention. But it's strictly depending on the anatomy.
Thank you. Any comment, Professor Abbas?
Yes, from Professor Senzolo, about gastric varices, would you recommend the prophylactic injection of glue in the fungal varices as a prophylaxis, primary prophylaxis, if the varices are large one. And second is there are 1 or 2 papers about primary prophylaxis of gastric varices using EUS guided coil and glue injection. So what is your opinion about that?
Since they bleed at a lower portal pressure, I think that it's true that especially when there are shunts, the primary prophylaxis with endoscopy, with which anocrylate, or even with more accurate techniques with a US guided injection, are more efficient than non-selective beta blockers. Anyway, evidences are scanty. And therefore, the current guidelines do not recommend this approach as a first line. I don't know, Dr. Tripathi, Professor Tripathi, what usually do, I do not go for endoscopy first.
So, yeah, I mean, I think I would, so if I saw, clearly, if it's not large, I go by the size of the varices. I think that's really important. And beta blockers, yes, taken, I think propranolol, carvedilol, but they may not have such a role because, as you've said, the portal pressure may not be that greatly increased. And so what I would do is if I saw large IgV1 and I was really worried, I would speak to my colleague who does EUS, and we offer EUS guided injection. We use thrombin with coils. And the good thing about EUS, you can actually see what you're doing. You can nicely see the varices, the flow, the feeder vessels, and the flow being obliterated more or less. That's really reassuring to see. You won't see that if you do blind glue or thrombin injection, but with EUS, and then we follow them up usually as a repeat, usually just one more endoscopy just to check, and it's amazing. The effect is quite durable. So we've just our data is going to be published very shortly. But again, it's a series, it's a case series, it's that level of evidence. So we haven't got really higher level evidence than that. And I think it depends on your institution and the experience that you have. And as I said, if I didn't have my colleague who's fantastic with the US, he's a radiologist, I wouldn't be able to offer this treatment to patients. But I think it definitely has a role, but the evidence is not so good.
Any comment, Professor Dogmeji?
Thank you very much. Not right now.
Thank you, Professor. Your excellent talk. Professor Jindal, your turn. Sharma.
Dr. Ankur Jindal, is he here? Dr. Jindal is Assistant Dean of APASL School of Hepatology, and I'm really thankful for this series which we started last year, and today it was the last session of this series 3. I'm really thankful to Professor Sareen, Professor Omata, and all the speakers, national, international, who had kindly consented to be our faculty for this, and all the moderators also, and also Izumi, who painstakingly coordinated all the efforts to bring out this wonderful session, which was attended by thousands of students and faculty all around the world, especially in the Asia Pacific region. For today's session, I am thankful to Professor Dheeraj, Professor Zagam, Professor Senzulu, Professor Dokmeki, Professor Kanda, Professor Mahmood Mapar, and for their active participation, and all the participants for their active participation. And I would like to close this session and this series also, and we will be coming up with the next series soon, and under guidance of our new president, Professor Shuchiro Sino. I'm also thankful to our past president, Professor Han-Chin Lee, for the continuous guidance that he has given us. And thank you very much for today's session, and have a nice day. Thank you very much. Bye-bye.
Thank you very much.
Thank you very
Thank
much.
you. Thank you for the invitation.
Dr. Kanda, thank you.
Dogmeji Sensei. Bye-bye.
Bye.
The confusion of the
Okay.
this injection.
さよなら。おやすみなさい。
はい、どうもありがとうございました。
おやすみな
神田
さい。
先生、元気ね。
元気です。
はい、どうも。
See you. Have a good night.
はい、バイバイ。